Okay, so we're going to talk about different types of dysfunctions that we might see in the hip and the pelvis, primarily hip joint pain and sources. And the first one that we want to talk about are femoral acetabular impingement syndromes, and or an FAI. And an FAI is really just an abutment of the proximal femur up into the acetabulum. Typically causes pain, but may lead to more significant problems, including labral tears and worst case scenario, we actually get some joint degeneration. So that's never a good thing, and acetabular impingements will present pretty commonly with pain and motion loss in flexion and or abduction. So if you have an athlete that or a client or an individual that comes in to see you and they start to have limited flexion or limited abduction, and they're complaining of a hip compression type pain in the anterior or anterior medial, kind of in that groin area, you need to start thinking about it in femoral acetabular impingement, and really kind of keep them out of that range and work a little bit more on hip adductors and the hip extensors. So the first type of a FAI is a cam impingement. And a cam impingement is on the neck, and it's where the neck will fail to taper down after it comes off of the femoral head. Typically occurs when there is an increase in load or force on the epiphysis, and it really just it leads to a poor clearance of the neck when the hip both abducts and flexes. Long term can cause the undersurface of that acetabular femoral head interface to wear down. You can have superior fraying of the labrum and ultimately a labral tear, and you can have kind of that superior aspect can result in that area there can start to result in degenerative changes. So we start to see some of the onset of osteoarthritis. The next type of femoral acetabular impingement syndrome is a Pincer impingement, and that Pincer impingement is when the acetabulum grows out and creates an increased coverage over the head of the acetabulum. Now, in this picture, we actually have a little bit of a combination of both a cam and a Pincer type of impingement. So we can have a mixed type as well. The Pincer type impingement, though, tends to result from increased loads during abduction, and you'll lose range of motion and get that increased impingement during abduction. So there's a greater coverage over the head of the femur with that type of impingement scenario, and increases the depth of the acetabulum, which we call a coxa profunda. Coxa profunda is a deepened acetabular surface. Again, we end up with wearing of the femoral head. We have compression along the superior aspect of the labrum, and fraying and degenerative changes over time. A labral tear can occur from a number of different sources, a number of different mechanisms, and it's not age related. So I'll have 17, 18, 19-year-old athletes that come in with cam impingements and secondary labral tears that occur. And a labral tear is typically a fraying or a tear of that labrum that provides a cushioning within the hip. And because it disrupts the articular continuity, we often have athletes that will complain of a clicking sensation or a pinching sensation that results. So, those athletes that have limited or painful internal rotation that kind of scours across the acetabulum, takes that into a deepened position, a more closed pack position where you get increased joint compression forces, typically will complain of pain, and that pain will radiate down into the adductor anterior and adductor region and anterior medial aspect of the joint. We only recently started really aggressively treating labral tears, and for a long time, kind of that hip pain in the younger athlete was just kind of left to rehab and left to let it quote unquote heal on its own, and in many cases would take the athlete out of their sport permanently. With the increased opportunity to address these issues arthroscopically, we're now able to deal with them a little bit more aggressively and with typically with very good outcomes. There are some risks associated with, though. I have a patient that I'm treating, and she had actually a second labral tear and went in to have it fixed arthroscopically. But during the scope, they apply a little bit of traction so that they can get the scope inside the joint. It's a fairly small joint surface, and as a result, she ended up with a stretch femoral nerve traction injury, and has been without quad function for 7 or 8 months now. So there is some risk associated, although the risk is small, and that's a pretty isolated case. Now, over time, we may see hip joints degenerate to a point of being pretty dysfunctional with arthritis, and this is a good example of a nice clean joint surface. On this uninvolved side, we've got space between the acetabulum and the femoral head. Nice looking joint on this uninvolved side, and on this side, boy, it's just really you can see the white fuzziness of the arthritis and the abnormal contour of the joint surface. This is a pretty normal looking osteoarthritic joint, and once that joint becomes osteoarthritic, the only way we're going to really fix it is with a total hip replacement. So we will look at either a posterior, lateral, or an anterior approach. I'm certainly seeing much more anterior approach to total hip arthroplasties now, and the outcomes are staggeringly good. Rarely do I even need to see a total hip replacement in outpatient physical therapy. They have 4 or 5 visits in their home after they come home from the hospital after a 2 to 3 day hospital stay. They're walking on it with a walker coming out of the hospital, and they're usually on a cane within 3 or 4 days. And these patients typically wake up without the arthritic pain that they had prior to the surgery. It's pretty remarkable. One of the less common injuries or problems that we see in the hip are Rutile Tendinopathies, and oftentimes I'll get that patient. They'll come in with lateral hip pain, and we'll say, okay, that's pretty classic greater trochanteric bursitis, And if we look at the trochanteric bursa here, which is underlying to the gluteus maximus, so we get some tightness in the gluteus maximus, and it presses up against the bursa and irritates the bursa to the point where it becomes inflamed. We'll see that lateral pain. But when I look at the insertion of the gluteus medius, we can have a tear, we can have a tendinopathy, a tendinosis, or even a tear in the gluteus medius. And we're starting to see a much better diagnosis with these patients when a injection into the bursa doesn't result in a resolution in their symptoms. We have to start looking at, is there a tear in the gluteus medius? And interestingly, I treated a patient that had a 2-year history of hip pain and multiple injections, and finally he had an MRI that showed a gluteus medius tear and hadn't really strengthened it at all. So we just kind of worked on getting him squared away with some exercises and increased his gluteus medius strength, and as a result, most of his pain, most of his dysfunction resolved without surgery. So there is a conservative approach depending on the significance of the tear. So we need to kind of look at how much weakness is associated with these tendinopathies, how much pain is associated with it, and what are the activities that cause the pain. In this particular patient, he wasn't even able to sleep through the night, and within about 3 weeks was sleeping through the night off all of his pain medications, but still felt weakness when he wanted to go for a hike, and wanted to be able to go back to snow skiing, and didn't feel confident in his hip to be able to go back to snow skiing at all. And then lastly, we'll spend a second talking about adductor strains, and we can kind of throw this into that whole conglomeration of growing strains. So hip flexor, kind of anterior hip flexor, and adductor, and these strains we will see in athletes that are very rotational in nature. So our soccer players and hockey players tend to be more prone to these adductor types of strains. And I think the reason that we see this is we see a mechanical weakness or linkage weakness between the deep abdominal muscles and the adductors and the abductors and glutes. So it's not that we necessarily have a significant weakness, it's that we have an imbalance, and we may not be functionally getting that hip or that glute to load, and as a result, in that extended position when the glute's not loading, the adductors and the hamstrings are coming in and saying, oh geez, my glutes aren't working, so I guess I have to. So as a result, they end up getting overworked and trying to maintain stability in that transverse plane, and they finally say, I'm giving up ship, and we start to see fibers disrupt and significant strains. And the problem with an adductor or hip flexor strain, that psoas type of strain, is their recovery time is pretty significant. So we really end up having it can be an injury that can keep somebody out for a significantly long time, and it may in fact result in what we will sometimes term a sports hernia or athletic pubalgia, athletic pubic bone pain, and again it's that breakdown in the stability of the multifactorial stability that surrounds the hip in 3 dimensions and in all 3 planes. So there's just some typical dysfunctions that we might see in the hip, and kind of be on the lookout for them, and as long as you understand the underlying mechanics, then you should be able to help a tremendous number of people that may come in to see you with this type of hip pain. Okay, until next time, let's keep working at it.